So whenever sir asks question or any students is having any doubt, you can unmute yourself and you can ask, and you can write in chat also. Then I will ask that question to sir. Okay. And sir, thank you very much for joining us with your lecture. Thank you very much for your efforts and time, sir. You can proceed, sir.
Sure.
Yeah.
So thank you, Shikunj and Dr. Pachore for giving me this opportunity to address the postgraduate students. Spondylolisthesis is a very interesting topic and very commonly seen in our practice. So by definition, it is slippage of one vertebra over the other. So when there is a forward slip of one vertebra over the other, it is called antilisthesis. This is generally the word used, spondylolisthesis, in the place of antilisthesis. They are exchangeable, though scientifically speaking, spondylolisthesis could also mean a backward slippage, which we call retrolisthesis. So in this particular picture here in the center, the image in the center that is on the left side, you can see both the phenomena happening, and this is quite common. So retrolisthesis, we'll not talk much about retrolisthesis, but I just want to make a point that retrolisthesis is usually a compensatory mechanism to maintain the spinal balance. Most of the times it is a compensatory mechanism, and it is most commonly seen in the upper lumbar levels. So here you see there is a L5-S1 antilisthesis, spondylolisthesis here, if you can see my arrow. So to compensate that, there is a L4-L5 retrolisthesis. So this is, L5 is moving forward, so the spinal balance is getting affected. So the L4 is slipping back on L5. So this is a compensatory mechanism. Again, here in the right upper corner picture, you can see there is spondylolisthesis at L4-5, L3-4, that is at 2 levels. And so the spine is, the pelvis and the lower spine is moving forwards. To maintain the center of gravity, the spine is compensating itself by moving retrograde. Thereby you see a retrolisthesis higher up, that is at 1-2 level. So mostly it is a compensatory mechanism, and you see this in post-operative patients. So here, for example, this patient has been fused from L4 to S1. Over a period of time, the patient, so to maintain balance, the L3-4 is slipping on the L3 is slipping on L4. This is retrolisthesis. And since it was symptomatic, since there was stenosis happening here, and since it was unstable, we had to go higher up. So we'll end the discussion of retrolisthesis. Again, it will come back later in our discussion, but at the moment we'll speak about antilisthesis alone. Now let me highlight this particular patient story. This is a 55-year-old active gentleman. He has significant back pain, significant mechanical back pain. Mechanical back pain is basically pain on movement, like getting out of the bed, bending forwards, turning in the bed, getting out of the car. So whenever there is a movement involved, the patient has significant back pain, and that radiates down to the leg. That is along the L5 dermatome. So you know how the L5 dermatome is distributed. Posterior lateral aspect of the thigh. So the buttock, posterior lateral aspect of the thigh, lateral part of the calf, and the dorsum of the foot. So you can see there is significant stenosis in the axial section. So here what happens is the traversing roots, they are in this corner here. The traversing roots get compressed in the lateral recess. So the lateral recess is made up of flavum that is hypertrophied, the capsule of the facet joint that is hypertrophied, and the bony hypertrophy of the inferior facet of the L5, L4, and the inner margin, the medial margin of the superior facet of L5. So this is called lateral recess. So that hypertrophies, that causes compression of the traversing root. So that is why the patient gets L5 pain. And this is because of degenerative spondylolisthesis. So degenerative spondylolisthesis is a situation where the bony arc is uninterrupted, it is unbroken, and there is listhesis, and there is compression of the traversing roots in the lateral recesses. It is similar to a lumbar canal stenosis, where because of the subarticular stenosis at L4-5, you get compression of the traversing L5 root. So this patient has significant instability. You can see the kyphosing effect in flexion. So this causes back pain as well as leg pain. And here the treatment option would be a fusion. You can't just decompress and leave, because the patient is having significant back pain. That is because of mechanical instability that has to be addressed. And if you don't address it, the patient will need to come for a second surgery, wherein you'll have to fuse him. And second is potentially is unstable. So there are many factors. One is age. He's a young gentleman, has significant low back pain. The facet joints are sagittally placed. I'll come to that in the discussion of degenerative listhesis. The facet joints are sagittally placed, and there is effusion. So this white structure seen here is this is called sandwich sign. Is basically fluid in the facets. That is a sign of instability. So this patient is unstable at L4-5 and he needs fusion. At the same time, this is a lady, a similar looking X-ray she has. She has a L4, L5 spondylolisthesis. She is housebound. She has no back pain at all. She has bilateral leg pain. Again, L5 dermatomal, and it is claudicant in variety. So all the features of the first patient are present in this particular lady. However, she doesn't have back pain, and she is housebound. Her activity level is low, and she is elderly. So if you see here, patient, so MRI again, it's done in extension. So when the patient has a standing X-ray which shows a certain degree of listhesis, which is in standing, which is load bearing, and when there is a MRI also shows no reduction. So in extension, the spondylolisthesis should reduce. If it doesn't reduce, that means it is a stable listhesis. It is not going to move much. So this patient also has stenosis. So the L5 roots are getting compressed in the subarticular area here in the lateral recesses. However, if you see the facet joints, they are more coronal and there is no facet effusion. And on flexion extension, the degree of listhesis is the same. There is not much kyphosing effect here. So in view of this, we just did a decompression. So this was a minimal axis decompression. So the patient has no back pain. She is elderly. She is housebound. Her work is not very demanding. She has stable facet joints. There is no instability in flexion extension. So this patient, we did a decompression alone without fusing. So this is done using a minimal axis technique. So the contralateral root is decompressed and the ipsilateral root is decompressed. Even on positioning, the degree of listhesis is the same. So if it reduces on positioning or if it reduces on doing MRI, that is a telltale sign of instability. So that you should always keep in mind as a clinician. So you could decompress it in a using an open technique or a minimal axis technique. The advantage of minimal axis technique is, it carries all the advantages of a minimally invasive surgery, like, better cosmesis, less blood loss, early mobilization, less injury to the paraspinal muscle so that the patient is back to work soon, lesser hospital stay, lesser blood loss, less scarring of paraspinal muscles. So that in a way is very much has a role in such situation, because if you do open surgery and do a typical laminectomy, you are injuring the posterior tension band. So you are cutting the interspinous ligament, you are cutting the supraspinal ligament, you are scarring all the paraspinal muscles. So the posterior tension band is getting affected. So probably there is a high likelihood of this patient getting unstable when if you do a wide laminectomy using an open technique. So this is another patient. So in the previous patient also, in the second patient also, you see the arc. So there is no lysis here. So the arc is maintained, the posterior arch is maintained. Okay. So then we come to a situation where the arch is disrupted. So this is called Spondylolytic Listhesis. Okay. So this is a 45-year-old lady. Patient has low back pain. Significant, again, this is mechanical in nature. So these patients get, there's a pattern to it. So in Spondylolytic Listhesis, so you could have two types of pain. So initial part of listhesis in the younger age group, you get more of a discogenic variety of pain. So what is happening is, so the spine takes the distribution of load in spine is such that 80% of load goes through the anterior column. So anterior column is made up of the intervertebral discs and the bony vertebrae. So the transmission of 80% of weight is through the anterior column. So initially, because of a loss of tension band posteriorly, patients tend to get pain on loading. So they get discogenic back pain. Over a period of time, this disc degenerates and becomes stiff. Then there is, pain in extension. So that is when the facets rub against each other. And that is the same time, because of narrowing the disc space, foraminal narrowing, they get root symptoms. So this patient has significant mechanical back pain and pain along the L5 dermatome. See, again, very interesting. So L4, L5 degenerative listhesis causes L5 pain. L5S1 lytic listhesis also causes L5 pain. If I can ask someone, if we can interact and ask someone, why would it be so? Can anyone answer?
Yes, anybody?
Yeah, so the same route which is traversing at L4-5 becomes a exiting route here. Okay. So can you see the arrow here?
Yes, sir. We can see.
So the L5 route, for example, the right L5 route. So this is right, this is left. So this is the right L5 pedicle. This is the right S1 pedicle. So the right L5, this is the right L5 pedicle. And this is right S1 pedicle. Now at L4-5 is the most common area to have a degenerative listhesis. Here the root goes down. Okay, so this is the superior facet of L5. So underneath this, the L5 root goes down. It kisses the subarticular area. It kisses the medial and lower surface of the pedicle. Okay, and then goes out. Okay, so when it is a degenerative stenosis, it is here that the compression is happening. That is the subarticular area underneath the facet joint, the medial aspect of the facet joint of L4, L5. And as it goes down here, so the pars break is just underneath the pedicle here. You see, the pars break is here. So here there is a lot of fibrous tissue formed and the L5 sags in front, because of which the L5 root gets hammered here. So L5S1 lytic listhesis, the lysis itself, because of fibrocartilage that is formed there, which is a natural process by the body to to heal the break in the isthmus, that causes irritation of the L5 root. So that you should remember. So here patient has back pain, leg pain. Again here it is claudican pain. So when the patient extends, the foramen becomes narrow. Okay, so when we stand and walk, it becomes narrow. The stand or walk, the foramen becomes narrow. That irritates the L5 root, and that causes pain along the L5 dermatome. So this is a case of Spondylolytic Spondylolisthesis. And again, very interesting. Now let me just go back to previous pictures. So in degenerative listhesis, this image is similar to a lumbar canal stenosis. It's just a variant of lumbar canal stenosis where there is anterior translation of L4 over L5. However, if you see here at L5S1, you see, what do you see here? Anybody?
Yes, anybody? Please be interactive. Residents take part in interaction. Yes, anybody wants to describe this MRI?
So here the canal is wide. It is so wide that you can swim in it, that wide. So you will not see any degenerative changes here. Okay. So if I go back again, you see this is the reason you have a degenerative listhesis, the origin of degenerative listhesis is degeneration, basically. As the term goes, degenerative spondylolisthesis, and which is the most common variety of degenerative most common variety of spondylolisthesis. So this is all because of degeneration. There is facet joint hypertrophy, there is ligamentum flavor hypertrophy, there is hypertrophy of the capsule, the disc has become hard. So you can see the canal has become small. Okay, so the compression here is inside the canal. In lytic listhesis, the compression is outside the canal. So the degenerative listhesis, the compression is appreciated in the axial view, whereas I'll show you in later pictures, the compression in L5S1 lytic listhesis is seen in the lateral views. You will see that the foramen is extremely narrow, and the pars interarticularis break, the fibrocartilage around that area is irritating the root. You can see that in the next, I'll show you in the next images. So this is, you get an oblong canal. So sometimes patient comes just with a MRI, they don't even have an X-ray, and just by looking at this oblong canal, okay, one can make a diagnosis of L5S1 lytic listhesis. If, for example, this patient comes with just a MRI, just looking at this, one can make a diagnosis of L5S1 lytic listhesis without seeing the X-ray. So this patient is young. Okay, so lytic listhesis, the symptoms usually present in third or fourth decade. Okay, degenerative listhesis is usually in the higher age group, which can range up to till they die. So so this patient is again young. This patient is highly demanding, and the root cause of leg pain here is a dynamic process. So every time there is a patient goes into extension, the pars break, the sharp edges of the pars break as well the fibrocartilage, they collapse into the foramen. They kind of buckle into the foramen and irritate the L5 nerve. So this has to be treated mechanically. There is no decompression here. It is a dynamic compression. It has to be neutralized by fusion. So what you do is we do something called as a TLIF procedure here. So we remove the disc, we put this cage of a big height, as big as possible, so that it open up the foramen. Okay, and to keep the foramen, cage in place and to maintain the height of the foramen, we fuse it. So this is the treatment of choice. And now we have another 72-year-old man who has non-specific back pain. There is no aggravating or relieving factor. Sometimes he gets night pain also. He basically comes with coccydynia, and when I see the X-ray, the patient has L5S1 lytic listhesis. It's not very uncommon. In many times, you will have patients who come with non-specific back pain, with coccydynia, with neck pain, with a lumbar spine X-ray, and you will see a L5S1, L5S1 lytic listhesis. So a majority of patients with L5S1 lytic listhesis are actually asymptomatic. Okay, it's only when the X-ray is done for some other reason that you pick up. But however, in an elderly patient who comes with back pain and whose symptoms don't correlate with the lesion, that is L5S1 lytic listhesis, you should definitely, and if it becomes chronic, you should definitely rule out other conditions which are common in an elderly person. One is, rule out malignancies, rule out metastasis, rule out, osteoporosis, which may be contributing to the back pain, multiple myeloma by doing a serum electrophoresis. After ruling everything else out is only, you know, where you can think of a degenerative process if the history is not matching with a lytic listhesis. Now again, this is a patient who's about 40-year-old. She's having significant back pain of 2 years duration and also claudication pain again in L5 dermatome. So anybody here want to take this one?
Yes, anybody?
Yes, sir. Yes, sir.
Yes, proceed.
Actually, there is no claudic. There is no spinal canal narrowing anywhere in this. Could appreciate, sir.
Yeah, so this patient has gone to about 10, 15 surgeons. Patient is also gone to a psychiatrist. You know, patient was sent to a psychiatrist and patient did take antipsychotic medication. So this is the problem when, you know, when you jump to a MRI.
Okay.
The patient has a lytic listhesis here. You see this?
Okay, sir.
And she's having significant lordosis and she's obese. So the, you know, abdominal pulls are anteriorly and the, you know, the extension, there is significant manifestation of root compression in the foramen. You can see this grade 1 listhesis here. So she had not got an X-ray done for 2 years. So the first thing you should do is a standing X-ray. Again, sometimes, you know, when you do a lying down X-ray, so in extension this reduces, right? So so that's why you should always do just like, you know, when you see a patient with osteoarthritis of a knee, where you ask for a AP standing load bearing X-ray, here also you should ask for a load bearing X-ray. That is a standing X-ray. So the reason I showed you all these cases is because, you know, it is not a homogeneous entity. So today's topic is spondylolisthesis. So spondylolisthesis is not one particular entity. Okay, it is just a definition of saying that, you know, one vertebra slips on top of the other. So it is heterogeneous in nature. You know, there are different etiologies. There are different symptom patterns. So you saw different etiologies. You saw, you know, degenerative listhesis in young and elderly. You saw spondylolytic listhesis. You saw symptom in terms of symptom pattern. You saw patient having dominantly back pain. You had patients who did not have back pain at all. You have patient having, you know, leg pain, and again different severity. Okay, so depending upon how chronic the disease is and how significant the slip is, they come with different different degrees of severity. Again, you also saw that there are different site of pathology. The same root is affected, but at different, you know, spots. And as you saw, you know, some could be just conserved, some could be just decompressed, some always need, you know, interbody fusion. So it is a heterogeneous entity needing, you know, various forms of treatment. That is the reason we need a classification. Okay, so this is a good classification. It was devised by these three gentlemen. They were one of the, you know, pioneers of the society called International Society for the Study of Lumbar Spine, ISILS. So they formed this particular classification. So this is more like a enumeration of the various etiologies. So it basically classifies spondylolisthesis of dysplastic, isthmic, and again there are three categories under isthmic, then degenerative, traumatic, and pathological. So the last three are fine: degenerative, traumatic, and pathological. But however, there are some deficiency of this classification. That is because, so the dysplastic and isthmic are you know, labeled separately. The issue is isthmic listhesis and dysplastic listhesis, they come under a common heading, because the dysplasia, whatever that is seen, it occurs mainly in the isthmic area, and that is the, you know, what do you call, that is the site of origin of most of the cases of spondylolytic listhesis. So that is one. So the isthmus is the what you call, it is the capital of dysplasia, that isthmic region. So you cannot separate dysplasia and isthmic. Second is this fracture, acute fracture, that is marked under isthmic. That comes under a totally different category when we already have a category for trauma. So that is one. Again, so whenever there is a trauma, because of which there is spondylolisthesis, you'll never get a uniform bilateral fracture happening along the pars. You cannot, just like a developmental listhesis, you cannot get a symmetric pars fracture by any kind of fall from the height or any kind of injury. If anyone hits on your back with a rod, you will not get a symmetric fracture in the pars bilaterally, which you can call. So it might happen at the level of the facet joint. It might happen at the level of the spinous process, lamina. It may not be symmetric, though it happens on bilaterally. So that's why this is the big fallacy of this particular classification. And the other issue is this particular classification doesn't allow you to think as to how this spondylolytic listhesis evolved. So that is when, to fill up all these deficiencies, this particular classification came about, which basically divides spondylolisthesis into two categories. So this was divided by Marchetti and Bartolozzi. They divide it into acquired type and the developmental type. So the acquired type would be, again, degenerative, which is the most common. Second is pathologic. So if there is any pathology, for example, if there is a tumor, a metastasis affecting the pedicles or the facets, because of which there is a slip of one vertebra or the other, then post-surgical would be iatrogenic. So you excised the lamina, you excised the facet joint, there is nothing left. So you're causing a iatrogenic listhesis because of, because of you injured the posterior tension bands, because of which one vertebra slips on top of the other. Then traumatic, acute fracture, stress fracture. So here they have classified into two. Acute fracture is wherein you have a fall from height and there is an injury to your spine, and there is one vertebra jumps on top of the other. This is not because of fracture in the isthmus. It could be anywhere. It could be happening at the level of the facet joints. It could be happening. It could be a through and through fracture to the spinous process and the lamina. It could be a fracture which occurs through the pedicle, which causes, which makes one vertebra jump on top of the other. So that is one. Second is stress fracture. Can I just hold on 1 second?
Yes, sure, sir.
Sorry. Can you hear me?
Yes, sir, we can hear you. Yes, sir.
So this is acquired type. So this is all not developmental. This happens because of either degeneration or either because of a tumor or because of metastasis or iatrogenic or because of a fall. So very simple to understand, acquired. So here, see, there is significant amount of stress given to the developmental type of listhesis. So this developmental listhesis usually centers around the isthmus. So when it is, so the more the dysplasia, the higher the potential for the vertebra to slip. So in lower dysplastic, so again we have lysis. So lysis is where there is a break in the isthmus, usually bilaterally, or there is elongation of the listhesis. Okay, so this causes spondylolisthesis. This depending upon the degree of dysplasia around that area, alpha S1 area, which I'll come to in the next slide. Next slide after this. So there are various markers of dysplasia. So it could be a they are, one is wedge-shaped L5 vertebra, rounded superior end plate of S1. It is called a sacral dome, a rounding of sacral dome. Okay, in this situation, even the pedicles at L5 are hypoplastic. They are small in nature. So whenever you're operating on these patients, you should see the dimensions of L5 pedicles. Though we tend to put 6.5 mm diameter screws in the lumbar spine, many a times you are pushed to use smaller screws at L5 because of the size of the pedicle. So that is one. You can have spina bifida occulta. So that also has relevance when it comes to surgery. So the higher or the more deformed these structures are, the higher the possibility of the slip to progress. So the next classification is basically grading. So this is to see to basically judge how much the vertebral body has slipped on top of the other. So the rule of thumb here is, this is mainly applicable for spondylolytic listhesis, not very significant when it comes to degenerative listhesis, because degenerative listhesis is usually a stiff kind of listhesis. It doesn't move much. It doesn't go beyond grade 1. It hardly goes beyond grade 1. So Meyerding's grading is basically to grade the slip in when it pertains to spondylolytic listhesis. Okay, it just gives you a severity. So if it is a grade 1 or grade 2 listhesis, we call it low grade spondylolytic listhesis. If it is grade 3 and above, we call it high grade listhesis. And these are totally two different kettle of fish, need to be managed differently. That we'll see in the next following slides. So I'm coming back to this classification again. So you see here in this particular picture, so look at the L4 vertebral body and look at L5. So L5 is wedged, you can see. It is trapezoid in nature. The sacral dome, you see, it is rounded. Okay. The more the rounding, the higher chance of wicket. It's very easy to imagine. It's like a ball, it's a surface of a ball. So the more the rounding of the S1 superior end plate, the more it is convenient for L5 to slip on top of S1. So the severe grades of dysplasia, they result in spondyloptosis. Okay. The lower grades just result in spondylolysis. That is just a crack in the isthmus. So usually in spondylolysis, which do not progress to spondylolisthesis or spondyloptosis, the dysplastic features are very minimal. Now, it's very important to understand what is pars interarticularis, where the dysplasia happens. So there are two. So when we expose the spine, there are two structures, two planes or two plateaus that you should be knowing about. One is pars laminaris. So this is the area. So this is this particular band, which you see, this red band here between the superior margin of lamina and inferior margin of the lamina. This is called pars laminaris. Okay, and this part which is between the two joints, so this is a superior facet, this is the inferior facet. This strip, this blue strip here, this is called the pars interarticularis. Articularis relates to joint. So the land between the two joints, this is the pars interarticularis. This is where the pars break happens. So this, once there is a break in the pars, the lamina, the spinous process and the inferior facet are separate from the superior facet, the vertebral body and the transverse process. So the superior articular process, pedicle, vertebral body and the transverse process, they move forwards. So when they move forwards, the shear stress is inferiorly directed. Because it is inferiorly directed, it closes on the foramen, thus irritating the L5 root. So this is pars interarticularis here. And this is pars laminaris. So spondylolysis, it's the lowest dysplastic form of spondylolisthesis. So there is just discontinuity of the pars. It could be unilateral or bilateral, it is quite common in the population. About 5 to 6% means 5 to 6 in 100 have this particular lesion, but many of them are asymptomatic. Okay. So this is a congenital. So this is not born. This is not inborn. So you don't get it at birth. It is not congenital. So it develops when you are about 6 to 7 years of age. It is said that when our ancestors were primates, so they used to be quadrupeds. They used to walk on the hands and legs that we have now. So gradually over a period of time, we became vertical. From being horizontal, we became vertical. So when the axis at which we became vertical, when you slowly got up and become straight, okay, the axis at which, the fulcrum at which we bend to become straight, that is supposed to be a weak area, and that is supposed to coincide with this isthmus at L5S1. So that is supposed to be the reason why, as a kid starts, standing up and starts walking, that is when it manifests as a crack, which is a spondylolysis. So how do you treat a patient who comes to you with spondylolysis? As I said, many of them are asymptomatic, and even when they come with back pain, rule out all other. So when a child, so it is a rule of thumb, when a child comes to you with back pain, you have to investigate further. There is no question about it. So because that is the reason is you usually kids don't complain of chronic significant back pain. They are always playful. So when a kid complains of significant back pain, when he withdraws himself from activity, it's usually an alarming sign, and you have to investigate. So you get X-rays. If X-rays are normal, you get CT, MRI. So when you clinically see there is spondylolysis, and if there is not getting better with conservative treatment, it's advised to do a bone scan, a SCEPT scan, after making a diagnosis of on CT, to rule out if this particular lysis is active or not. So if it is active, it shows as a hot. I'll show in the next slides. It shows up on a bone scan, and these are situations wherein a pars block works. So there's a lot of inflammation around in that area, so that causes pain, and you can give a pars block and patients can get relief. However, if it is a cold scan, then it won't generally work. So the line of management in a patient with spondylolysis is, to strengthen the core muscles. So these are basically flexion exercises, analgesics. If the patient is having severe pain, advise bracing, and till the pain comes down. If the patient is a sportsman, etc., you will have to hold him back from doing those because that will aggravate it till the pain gets better. So very rarely you need to do lysis blocks. And very rarely you also need to do a lysis repair. So lysis repair is a non-fusion surgery. So what you do is, so you don't want to fuse this particular level when there is lysis. It is not unstable. It is just the crack in the isthmus is just causing pain. So what you do is you can fuse that area, and you can maintain the movement at L5S1. So this is very rarely done. So there are various ways of doing a pars repair. You can use a tension band principle that is used here. So you pass the wire around the spinous process and around the superior articular process and tighten it. You can put this small 2.7 millimeter diameter screws across the pars break, or so this is, I think this is the only case I've done in my lifetime. So here you put pedicle screws, and you use these pedicle, these laminar hooks. So the laminar hook hugs the inferior margin of L5. The pedicle screws goes into L5 pedicle, and you compress the screw and the hook to get between the hook and the screw, and put bone graft in the just denude the fibrous cartilage or the pars and pack it with bone graft. So this is a very rarely done surgery. So then we move on to spondylolysis. So spondylolysis patient progressing to spondylolisthesis, very rare incidence. It is about 4% to 5%. So majority of patients even don't show up in our clinic, those who have spondylolisthesis. So it's also very important to understand and note, this is very important to remember that 28 to 42% of patients with spondylolysis, with progressive spondylolytic listhesis have spina bifida occulta. What is the relevance of this? Can I ask anyone?
Yes, anybody?
Is there any, sir, vertebral dysplasia?
So there is spina bifida occulta, you can see here. So there is no spinous process seen here. So the relevance is when it comes to surgery. Okay. So when it comes to surgery, when you're exposing the spine, I hope many of you have got exposure to spine surgery, right?
Yes, sir.
Yeah. So when you're exposing, your cautery will get into the canal and you will have a dural tear.
Okay.
Okay, so before you embark on any surgery for spondylolytic listhesis, I always tell my fellows, make sure that there is no no spina bifida occulta. Okay, so when you exposing, you don't notice it, you don't you ignore it, in absent-mindedness, and your cautery gets into the canal, into the dural sac, and you have a
Sir,
leak.
is X-ray is enough, sir, or CT is also required definitely for ruling out spine?
You can see.
Okay, sir. Okay, sir.
No, so risk factors of progression, basically all those dysplastic features which I spoke about, that is wedging of L5 body, rounding of the sacral dome, hyperlordosis, and also there are considerations like, if the patient's listhesis is detected at a younger age. Okay, so a patient starts complaining of at 15 to 20 years of age, then it is when it's already grade 1. Okay, so you can expect over a period of time, in the next 5-10 years, it might move on to grade 3. But mostly these patients come to us when they are in their 3rd or 4th decade, because what happens is initially the disc between L5 S1, so when there is a break in the tension band, so as I said, 80% of the load goes through the anterior column, 20% of load goes to the posterior column. So when there is a break in the posterior column, okay, so the entire load goes through the anterior column. So there is nothing going through the posterior column. So if you see the L5S1 facet joints, okay, maybe in the next few MRIs will show, you see the L5S1 facet joints in L5S1 lytic listhesis, they look fresh, they're unused. There has never been a movement at that particular level. So when the 100% of load goes to the anterior column, what will happen? The disc degenerates fast. Okay, the L5S1 disc degenerates fast. Okay, so this causes significant back pain. Okay, so this significant back pain, then also, there is irritation of the surfaces here, of the pars surfaces against one another. So that causes pain in extension. So they get pain in flexion also, as well as in extension. And along with that, because the disc degenerates and it narrows, it becomes, initially it was tall, then it heights decreases because of degeneration. That narrows the foramen. And with time, there is increased fibrocartilage formed at L5S1 at the level of the pars. So all these manifestations narrow the foramen further, causing compression of the L5 exiting route. So that's why you don't develop symptoms immediately in the first 2 to 3 decades. Only when all these degenerative changes manifest and progress, that you get then that the patient becomes symptomatic. So it's very important to understand where all, you can get root compression. So this we already discussed. So in degenerative listhesis, it is at the level of the facet joint, that is inside the canal. When there is lytic listhesis, it is just underneath the pars, because that is a pars break, formation of fibrocartilage that causes irritation. Then, extraforaminal is when, when the, again, it's usually degenerative in nature, when there is a collapsed disc height osteophyte formed in the extraforaminal area. It's usually a more common site for extraforaminal disc herniation rather than stenosis. So usually we get back pain, mechanical back pain because of disc degeneration, as well as, abnormal movement occurring at the level of the pars, plus L5 root symptoms. Very rarely, in situations where there is spondyloptosis, there is 100% or more than 75%, listhesis of one vertebra over the other of L5 over S1, that you get, S1, S2, S3 root symptoms when the dural sac is stretched over the sacral dome. So you see here, I was talking about this, a case of L5S1 lytic listhesis. These facet joints, they have hardly been used because all the movement that has happened at L5S1 level, it has happened at the level of the pars, not at the level of the joint. So again, these patients, they have, during adolescence, when they come to you, mostly they're asymptomatic. When they are symptomatic, again, it is similar to spondylolysis. You counsel them, you advise them exercises, you give them braces, do pars repair, pars block. Very unlikely to do a pars repair. If the symptoms are extremely severe, then you need to fuse them. So look at this particular series of events happening at L5S1 in one particular patient. So this same patient whose X-ray was done from 1986 onwards till 2003. So you can see the progression of the listhesis, right? Can anyone also remark on anything else that is happening here?
Yes, anybody?
Disk space is reduced.
Progressive decrease in the disc space,
Correct.
and increase in the spondylolisthesis.
So basically, the increase in the spondylolisthesis
from grade 1 to grade 3.
Yeah, so the increase in listhesis, you can say it is a manifestation of disc degeneration. Okay, as the disc degenerates with time, okay, the vertebral body keeps slipping forwards. So it is a function of disc degeneration, the listhesis. So this is a case of low grade listhesis. Okay, so low grade is grade 1 or grade 2. These patients just if they still continue to have pain, back pain, leg pain, etc., you consider fusion. So again, as I was talking about, so there is no dynamic compression happening here. So this is the foramen, okay, and this is the L4 root coming out between L4 and L5. Okay, and if there is a isthmus break here, and if there is a slip here, the L4 root will get involved. This is L5. So L5 pedicle, underneath the L5 pedicle comes out the L5 root. So the fibrocartilage here at the pars, plus the collapsed foramen because of a collapsed disc. All these together cause compression of the nerve root here, exiting root. So these are the sharp edges of the pars interarticularis, which impinge on the nerve root. That causes leg pain. So there is no static stenosis that causes pressure on the root. As I said earlier, the canal is free. It's dynamic compression. Mobility causes fibrocartilage. So the movement, so extension. Okay, extension makes this fibrocartilage buckle into the foramen and cause irritation of the nerve. So the goal here in surgery is you excise the disc, okay, put in a big size cage, okay, that opens up the foramen and neutralize the movement that is happening here. That is by putting screws and rods. So this is what I was talking about. In spondylolytic listhesis, you look at the parasagittal views. In degenerative listhesis, you look at the axial views. So here you see this, you can compare with the foramen higher up. So this is L4-5 foramen. So this is the L4 root. So this is the L4 pedicle. Underneath the L4 root, pedicle is the L4 root. So there is buffer space around this area. Okay. So here at L5S1 listhesis, you see this pars break here. So that is buckling into the foramen. This is the root. Okay. And this is the hard disc. So all these contribute to compression here. Okay. And also appreciate the size of the pedicle here. So look at the pedicle size here at L4 and look at the size of the pedicle here at L5. Okay. So if you are overconfident, put a large diameter screw here, it will irritate the root. Okay. So this small pedicle is again, as I said, a manifestation of the dysplasia occurring at the L5S1 area. So generally what happens is, why all these manifestations happen, I'll show you in the next few slides. So there is lumbosacral kyphosis, there's flat buttock, there is thoracolumbar hyperlordosis, because the upper trunk shifts in front, the trunk looks short, and because of that you will also get a transverse abdominal crease. Okay, because one part, the upper part of the abdomen is jumping on the pelvis, so you'll get a crease. And all these are compensatory mechanisms. The lumbosacral kyphosis, flat buttocks, thoracolumbar hyperlordosis, flex hips and knees. And because of all these features, patient has a waddling gait. So all these compensatory mechanisms have a role in management, and I'll be discussing that when it comes to management. So on examination, because of the pain and instability, the movements are diminished. One can appreciate a step here. Can anybody tell me what a step is?
Yes, anybody?
The gap between the two spinous process which is felt in the posterior aspect.
Yeah, so as you palpate the spinous processes, you'll feel a jump, at L5S1. That is because the L5 at L4, L5, so at L5S1. So the L5 vertebra is moved forward. Okay, and you get L5 root related symptoms. So in severe cases, what will you get? You will get EHL, EDL weakness. You might get a foot drop. Okay, this is in severe cases. This is very unusual in spondylolytic listhesis. So when it comes to management, okay, basically you depend on X-rays and MRI. Rarely do you need to do a CT scan. So this is a patient who comes with an MRI. Okay, a patient is having significant back pain, significant pain in the thigh. And again, similar to the previous patient, she's seen many doctors with no relief. Anyone?
Yes, anyone wants to describe this MRI?
It appears to be normal MRI, sir. There is no disc or no listhesis. There is a
You'd like to get the X-rays.
Get the X-ray, sir. Yes, sir. X-ray is we would like to get, sir.
So you never asked me where the pain is.
Okay.
Do you want to know more?
Yes, sir.
So I just said thigh pain.
Okay, sir.
Do you want to know more?
Yes, sir. Hip could also be a cause, sir.
If you ask me anterior or posterior thigh pain, I would answer it as anterior thigh pain.
Then upper lumbar is involved, L1, L2, L3.
So the patient has a pain higher up.
Upper number. Okay.
It's not unusual. It is not common, sorry, but you can still have a listhesis happening higher up. So 5, 4, 3. So L3. Okay, L3 pedicle. So L3 root. So the patient has anterior thigh pain, which is not noticed on the MRI. Okay, so always get a standing X-ray done. You will make a lot of diagnosis. You will not miss pathologies. So again, the treatment of choice is symptomatic treatment. In such patients, you treat them initially conservatively. Not that you're preparing them for surgery. A majority of them might just get better and not come back to you also. So give them analgesics, ask them to do flexion exercises, especially patients who are athletes, etc. They have very good musculature, and you just need to do core strengthening exercises. They'll never come back to you again because they get good relief. When it comes to surgery, you can think of giving root blocks if it is okay with them, and you target the exiting route. So when it comes to
one doubt, sir. Regarding whether we have to go for flexion exercise or extension exercise, sir. In case of disc, we tell extension exercises.
Here always remember it's flexion exercises. Okay, so it is only in flexion that the foramen opens up. So whether it is degenerative listhesis or spondylolytic listhesis. See, there are various reasons. When they come into your clinic, they always come with a flexed attitude. Okay, so that means they are relieving themselves of some pain in a flexed attitude. Okay, you can tell the relatives. You can ask the relatives also will complain. I've been telling my mother, whoever the patient is, to walk straight, but every time I tell them, she gets irritated. She keeps, after a few 2-3 minutes, again she leans forward.
Okay,
that's what.
Sir, in extension exercise, is it helpful in disc, sir? As PIVD?
Yeah. There you are unloading the anterior column, right?
Okay, sir.
So again, in degenerative listhesis, it is like lumbar canal stenosis. What happens in lumbar canal stenosis? It's called shopping cart sign. You bend forwards. Okay, so that is a clue that these patients are getting relieved of themselves with flexion.
Okay. Thanks, sir.
So when you tried everything, when nothing helps, so then there's nothing except surgery that you would advise. So the principles of surgery are, the goals of surgery are, one is to get a good decompression and a solid fusion. And you are achieving both the goals with the same, using a one particular method, that is by, fusion. That is by fusion in the sense by indirectly decompressing the nerve root, by jacking up the disc space, so if you get a good disc height by putting a big large size cage, you are also collaterally increasing the size of the foramen. So that unbuckles the fibrocartilage, that opens up space for the nerve root, and because you're putting screws and rod and fixing it, that stops all the motion that is happening at that particular level. So that is the way patients get relieved of the pain. So just moving a bit away, not away, but this is related to management principles. This is a very important topic and concept that one should understand. This is basically a bit advanced for postgraduates, but now every treatment strategy in patients is based on this. This particular concept. So it's very important to understand, sagittal balance. To understand any pathology, to understand treatment principles in a patient that comes to you. So this is the cone of economy. You guys have read about it? Cone of economy?
No, sir.
So nothing offbeat. It's very simple to understand. Okay, so when you're standing straight, okay, so if we can develop imagine two cones around you when you're standing. Okay, if you tend to lean towards the outer cone, okay, and walk, you'll be spending more energy. Okay, compared to a situation where you are in the inner cone. So when you are bending and walking, your body needs more energy to propel you forwards. Okay, compared to a situation where you are in the narrower cone. So more endurance. Okay, So if you're inside this inner cone, there is more endurance. When you're, outside this cone, so if you imagine yourself bending forwards and walking, you spend more energy. Okay, so this is called economic equilibrium. That is what the goal of any spine surgery is. So patient comes with spinal deformity. We try to get him into this particular inner cone because we want him to spend less energy when he walks. So any patient who is leaning forwards like this and getting into the outer cone spends more energy. So this is very important to understand. So there are ways of correcting a patient who is in an outer cone to get him into the inner cone, that is in an upright posture. The reason you're spending more energy is your posterior muscles. So the erector spinae muscles have to work harder to make you straight. So that is why you spend more energy. And most patients, they have poor erector spinae musculature because they don't exercise, most of patients. And there's something called as sarcopenia, loss of muscle fiber with aging. So that aggravates the situation. So it is called, so life is called a kyphosing event. Okay, most structures in the spine are such that they tend to add kyphosis to you. So it's called kyphosis begets kyphosis. Once there is kyphosis, there will be more kyphosis for various reasons. And one of the reasons is poor erector spinae muscles, and the energy that the body has to spend to try to make you straight is enormous compared to a situation where you are totally erect. So that is the basic concept. And so these are some important parameters which are related to the cone of economy, which you should know. So this particular angle, okay, so this is the superior end plate of S1, okay, and the base of this cone of economy is the pelvis. Okay, if your pelvis is tilting forwards, okay, then, and if your spine is not balanced, it goes off gear. Okay, it might lean forward. So the foundation is what what you call it, the foundation, which is the pelvis. This is the foundation on which your spine is standing. So you need to have a right balance in the pelvis to get a proper alignment higher up. So, so this is called, so there are some measurements in the pelvis that you should know. So this is the superior end plate of S1, okay, and this is the femoral head, okay. So there is this line which is perpendicular to the superior end plate of S1, and there is a line which goes from the same point to the, so this is at the center of S1 superior end plate, and this goes down to the center of femoral head. So this is the relation of pelvis with regards to your femur, okay. This is always a constant in a patient, okay. So this usually is about 50 degrees with a range from 35 degrees to 85 degrees. Okay, normally it is usually around 50 degrees. A person who has a high pelvic incidence, okay, high pelvic incidence, so in the range of, for example, 75-80, has a higher potential to compensate. So this I'll come to you later. So he'll have a more horizontal sacrum, okay. So his sacrum will be more horizontal, a person who is on the higher end of the spectrum, compared to a person who has 35-40 degrees of pelvic incidence. His pelvis will be straight. So he has a lower potential to compensate. Again, as I said, I'll come to this compensation thing later. Now, there are other two measurements which are related to pelvic incidence, that is the sacral slope. So this is the angle made by the superior end plate to the horizontal. Okay, this is called the sacral slope. So the higher, the higher the the more horizontal the pelvic incidence, the higher will be the sacral slope. Okay. So again, there is another line which is the angle between the vertical down through the femoral head and the line joining the superior end plate at the center to the femoral head. This is called a pelvic tilt. Okay. So the more vertical the pelvic tilt, the more vertical the sacrum, the higher will be the pelvic tilt, because as the pelvis becomes more vertical, the pelvic tilt will increase. Okay. So again, a person with a low pelvic tilt has a higher possibility of compensation because he has a horizontal sacrum compared to a person who has a high pelvic tilt. A person who has a low pelvic tilt. So person with a low pelvic tilt, okay, has a more horizontal sacrum. Okay, a person with a high pelvic tilt has a more vertical sacrum. Okay, he'll have less capacity to compensate. Compensate meaning from horizontal to becoming vertical. So this is a bit complicated, but this is very important for you to understand. So a patient with a high pelvic incidence angle has a greater potential for pelvic retroversion. You see here, person who has high pelvic incidence, that is what we meant in the range of, somewhere between 60 and 80 degrees, he'll have a more horizontal pelvis. Okay. And as I said earlier, this is an important understanding when it comes to analyzing compensatory mechanisms. So if I was showing you directly, I could have explained it better. So you can imagine, so the pelvic incidence, if it is high, so for example, this is 80 degrees, this particular angle, so then it will be more horizontal. Okay. Suppose it is less, okay, it will be more vertical. So when so as I described earlier, so a patient with a high pelvic incidence like here, okay, will have a higher sacral slope compared to a and a lower pelvic tilt. But whereas a patient with a vertical pelvis, means anteverted pelvis, a vertical sacrum, will have a higher pelvic tilt and lower sacral slope. Okay, this particular situation, okay, where there is a vertical sacrum or a retroverted pelvis, this doesn't compensate well, and this is very important to understand the management principles. So when there is a spondylolisthesis, for example, here there is alpha S1 spondylolisthesis. So the trunk is getting pushed anteriorly. Okay. So this is easy to understand. The trunk is getting pushed anteriorly. To compensate this, as I described in the first few slides, the upper lumbar spine compensates. It goes backwards. Okay. To maintain the center of gravity. Okay. I hope you understand. So when this trunk goes forwards, okay, it is leaning forward. So the upper part of the thoracolumbar spine goes posteriorly. So this is to maintain the center of gravity. Okay. So that is one way of trying to get your balance right by the body. So then when that limit is reached, so then there is no more possibility of the thoracolumbar spine to, go posteriorly. Then this particular sacrum, okay, you can see now it is kind of somewhere between, horizontal and vertical. So then when the limit of achieving thoracolumbar lordosis is achieved, then to maintain the center of gravity, the pelvis becomes, the sacrum becomes straight. This is called retroversion. So you can see here. Okay, this becomes straight. It becomes a vertical sacrum. So this is called retroversion. Okay, so there is retrolisthesis or lordosis happening at the upper lumbar levels, okay, to maintain the center of gravity, and on the lower side there is verticalization of the sacrum to maintain the center of gravity. When it goes beyond this, okay, when it goes beyond this, where does the compensation occur? It occurs at the level of the knee joint. So when, see, as you see here, this is a horizontal sacrum. Gradually over a period of time, because of compensation, it is becoming vertical. Okay, when the limit of pelvis to maintain itself vertical is reached, so then it is the hip joint. It goes into it is the knee joint which goes into flexion. So these are all compensatory mechanisms. So for example, this is a patient. For example, there is you can see on the right picture here. So there is lordosis and retrolysis occurring at the upper levels, okay, to maintain balance. Okay, there is verticalization of pelvis. Once that limit is reached, the knee goes into flexion to maintain the center of balance. So this is the principle guiding the management. The other concept one you should understand is, so suppose the patient is not able to compensate at all these levels, okay, because the limit has reached, so then the patient tends to bend forwards. Okay, when the patient tends to bend forwards, that is when this particular line gains prominence. Normally, the C7, midpoint of C7 vertebra, when you draw a vertical plumb line, it usually goes through the superior end plate of S1. Okay, so when there is when it gets overcompensated, when the body leans forward, it goes into an imbalance. The C7 plumb lines moves forward. So then the spine as well as the body is not balanced. Okay, so when you lean forwards, okay, you can see is there is a alpha S1 listhesis. The pelvis is vertical, and the body is not able to compensate further. So the SVA is increased. Generally up to 5 centimeters of SVA. That is a vertical line down from the S1 down from the posterior aspect of the alpha S1 disc space. So that is it should be less than 5 centimeters. So when there is significant decompensation and when the body leans forward, okay, in a significantly listhetic situation, so there is loss of sagittal balance. Okay, so it keeps leaning forwards. Okay, so this is called positive balance, severe positive balance. So it keeps leaning forwards because all compensation mechanisms have lost. Okay, the thoracolumbar lordosis has reached its limit. The pelvis has become vertical. The knee is gone into flexion. In spite of that, beyond that, the body is not able to compensate. That is when it leans forwards. So this is also seen, as I said, in a situation where the patient has, by birth, a low, by constitution, if the patient already has a vertical sacrum. So if it is in the lower ranges of normal, so if the patient already has lower pelvic incidence, a vertical sacrum, so there is no much compensation that is possible. So it is not in all patients where they have reached their levels of compensation. It is also in persons who have lower pelvic incidence, okay, by constitution, they cannot compensate much, okay, and those patients who have significant disc degeneration higher up, okay, at L5, at L4, 5, L3, 4, thoracolumbar region, if there's significant degeneration, so then they fail to decompensate, to fail to compensate. So what I meant to say was, if the patient by constitution has a vertical pelvis and a alpha S1 lytic listhesis, okay, high grade, and he has no mechanism left here because of degeneration at multiple levels, there is no much movement happening here, and he is already compensated by flexing his knee, then the only way, then it goes into imbalance because his body mechanism, because of vertical pelvis, because of limitation in the lumbar spine, he's not able to balance. So his body leans forward. So this is called an imbalanced pelvis. So now the treatment is basically based on these three, considerations. One is the grade of listhesis, one is the degree of pelvic incidence, and third is the spinopelvic balance. Okay, so let's go to that. So patient with alpha S1 lytic listhesis, you first classify them into low grade and high grade. So first you classify, as shown here, classify them into low grade and high grade. Now again, in the low grade, low grade is not a big deal at all. Okay, so whether it is low pelvic incidence, medium pelvic incidence, or high pelvic incidence, the spine is always in balance. In these patients, in low grade listhesis, the treatment is decompression and fusion, which we call TLIF. Okay, TLIF procedure, whatever be the pelvic incidence. So it is only when it comes to high grade, okay, we divide them into balanced pelvis. So in a person who is able to balance it well without compensating, that is type 4. Okay, and then you come to the situation where they have tried to balance. Okay, when there is a retroverted pelvis, okay, patient can be divided into a balanced pelvic spine and a unbalanced spine. So here you have two situations in a high grade listhesis. One is balanced pelvis. So you have the entire spine is in balance without any compensatory mechanisms. And here in retroverted pelvis itself is a compensatory mechanism. So with compensation, whether you are balanced or whether you are not balanced, okay, the treatment protocol plays a big role in differentiating balanced pelvis versus a situation where there is a balanced pelvis as a result of compensation, or in spite of compensation, it is not balanced. So here, the type 1, type 2, type 3, type 4, you do an in situ fusion because the entire thing is balanced. The entire spine is balanced. But when it comes to a situation where there is retroverted pelvis, okay, there you need to reduce the listhesis and fuse it because there are two types. One is balanced spine. Okay, so because of all the compensatory mechanisms, it is balanced. So okay, when you fuse it again, if you fuse it in situ, you are straining the body because it is because of compensation that the spine is straight. Okay, and in spite of compensation, if it is if it is unbalanced, that means you need to reduce it to get it into balance. So that is the reason you have to reduce it and fuse it. So this is a balanced pelvis. Okay, C7 is going is in the line of femoral head. Okay, here again C7 is in the line of femoral head, but because of a vertical sacrum. Okay, this is retroverted and balanced, and here, so the C7 is going in front of the femoral head. So here it is retroverted but still not balanced. So these are the two situations where you need to do a reduction and fusion. So this is low grade, okay, with low PI, low grade with normal PI, that is pelvic incidence, low grade with high PI. Whatever be, the amount of the value of the PI, you can fuse in situ because the spine is in balance. And again here, okay, balanced pelvis. So without any compensatory mechanisms, the balance is maintained. Again, you can fuse it in situ. So here in high grade, compensated, you have a retroverted pelvis which is compensating, but the spine is balanced. So you don't want to strain the compensatory mechanisms. That's why you reduce it and fix it. Again, it is totally into imbalance. You have to get the L5 on top of S1 to get your balance right. So this is to differentiate the low grade listhesis, okay, there are two mechanisms. A situation where there is increased lumbar lordosis, which causes shear stress at L5 S1. So this is one type of low-grade listhesis. The other is a less lordotic, but here the mechanism is called a nutcracker effect, because of which there is listhesis. This is for academic interest alone. So when it comes to treatment of choice, what exactly you are doing with or without reduction, it is basically a TLIF procedure. It is one of the commonest spine surgeries done in our practice, and the fusion rate is close to 90%. So this is a gold standard procedure. So what you do is there is a midline incision, exposure of the posterior spine by by reflecting the paraspinal muscles. You expose all the way till the transverse processes. You insert the pedicle screws, do a facetectomy on the affected side, and through the interval between the exiting route and the traversing route, you can see that particular area is called the window of opportunity. So you do a discectomy and you do a thorough discectomy, prepare the end plates and hammer in a cage, and screws you already put into the pedicles. You connect them with a rod and compress. Compression is important. One is to hold the cage in space so that it doesn't migrate posteriorly. Second is, because you packed it with bone graft, you want to achieve compression across the disc space for fusion. So that is one reason. Third is to achieve lordosis of the segment. So these are the three reasons why you compress it and close. So radiologically, these are the steps. Once you expose and identify the level, you put your pedicle screws, check they are in in the right place, optimum, medially directed, optimally, and then next is when you're hammering in your cage here, so that you know the limits of the cage anteriorly as well as posteriorly, and then once you put the rod in and compress. So this is a picture of a patient who's undergone a TLIF procedure. So this is what we do now. We do it with minimal access. It's a navigated TLIF.
The video demonstrates a case of minimally invasive navigated TLIF in a case of L5S1 spondylolytic spondylolisthesis. As you see here, it is a mobile lytic listhesis. The patient is positioned prone under general anesthesia. Tracker is applied to one of the spinous processes of the upper lumbar vertebra. The isocentric C-arm takes a spin around the patient and delivers CT images which are merged to the navigation console. Navigable Gemshini needles are used to make entry into the L5 and S1 pedicles on both sides, and guide wires are passed through the cannula of the Gemshini, and these guide wires are anchored to the patient's ribs. Navigable taps are used to make tracks for the pedicle screws. Special reduction screws are used in this situation. They are passed into the L5 and S1 pedicles on the opposite side of the symptoms, that is on the contralateral side of the symptoms. Now, on the ipsilateral side of the symptoms, a series of dilators of increasing diameter are passed in the intermuscular plane to create a temporary portal on which a final tubular retractor is docked in the trajectory of the L5S1 disc, which is verified with the navigation probe. A vertical osteotomy of the left-sided L5 inferior facet is performed. These are the usual steps of a TLIF procedure. Following this, a horizontal osteotomy of the left-sided S1 facet. This is the window of opportunity through which a discectomy is performed. Following the facetectomy, a laminectomy procedure on the ipsilateral is performed. This is basically to identify the dural sac and the exiting nerve root. Remember, in spondylolytic spondylolisthesis, it is the exiting root that gets trapped underneath the fibrous cartilage of the defective pars interarticularis. So it is necessary to isolate the exiting L5 root and then identify the disc space. Once the disc space is identified, a box annulotomy of the L5S1 disc is performed using a series of various instruments like the discectomy forceps, the shaver, the curettes. Discectomy is done. In the case of degenerative spondylolisthesis, there is stenosis circumferentially. So one needs to do a thorough decompression, which is done by angulating the tube on ipsi and contralateral sides. You saw the amount of bone graft that was harvested using the lamina and the facets. So the disc space is prepared using disc cutters, various sizes of shavers. Now we go back to the contralateral side, where using an interesting mechanism, the rod is passed and the listhesis is reduced. So this mechanism is called the sextant mechanism. It's a very interesting way of measuring the rod size using the principle of opposite angles. The rod is attached to the sextant and the rod sits on the tulips of the S1 and L5 screws on the opposite side. Initially, the S1 pedicle screw is fastened with an inner nut, holding the rod in between, following which, using a special reduction maneuver, as you see here, the L5 screw is pulled up gradually. That can be witnessed in the C-arm. Using this particular mechanism, the spondylolisthesis is reduced. Now we come back to the ipsilateral side, that is on the side of the symptoms. After doing the cage trial, anterior 1/3 of the disc space is packed with locally harvested bone graft. It's called the sentinel bone graft, followed by impaction of the cage of the right size. So then you can see these screws being driven into the ipsilateral S1 and L5 pedicle. These are the post-operative images, and this is the final end product. And these are the benefits of 3D navigation. Thank you.
So could you see the video?
Yes, sir.
Yeah. Are we running beyond time?
No, not at all, sir. Not at all.
So basically, this was the minimal access TLIF. The same steps of surgery are done using small incisions. So you pass these guide wires, then pass the screws, then you do put screws on the opposite side of the symptoms, and you distract, and then you pass a tube on the ipsilateral side, excise the facet joint, reach the disc, remove the disc. By basically you're indirectly decompressing by creating, putting a big size cage. So navigation helps in, getting your screws in the right position. And during the steps of surgery, to know where you are, the navigation probe can guide you as to, where exactly you are. That helps in determining the exact position of the cage, etc. So the advantages are, you are precise. You know the exact diameter of the screw that you are going to use, and you're going to put it in the right, best, trajectory. And basically helps you with radiation. Otherwise, if you're using a C-arm, you take at least 60 to 70 shoots in one surgery. So these are the various steps. So does anyone know which implant this is? This is a trick question.
Schiller's hook plate. Schiller's hook plate, sir.
Huh?
Schiller's hook plate.
No, this is hard shield rectangle and sublaminar wires.
Actually, subliminar.
So what is the goof up here? So there is a lytic listhesis, okay, which you're going to treat. So the goof up here is you need to take a purchase in the anterior part. I told you the pedicle, the superior facet, the transverse process, and the vertebral body are moved in the front. Okay, the lamina is left behind with the inferior facets. So you need to take a purchase in the fragment which is moved anteriorly. Okay, so here they pass the loop around the lamina, which is already with the inferior segment itself, where they already put a loop. You getting my point?
Yes,
So
sir.
prevent this from going ahead. So you put wires along underneath the lamina of L5 as well as underneath the lamina of S1. Okay, which
Wrong
was
level surgery.
posterior.
Wrong level surgery, sir.
Not a question of long level, it's a wrong application. You have to put, so this is not a right implant.
Okay.
So when you put, when you're fusing L5 to S1 for a lytic listhesis, okay, we are fusing that part which is slipping in front to the part, to the S1 body. Understand? You are fusing S1 to L5 to S1. Here, the L5 body has gone ahead, leaving the posterior elements. So the posterior elements are already with S1. So this is a wrong implant to be used here. So as we discussed in that classification, in high grade slips, okay, in high grade slips, so there is to always, before this classification came up, this is the only classification which guides surgery. So the Wiltse-MacNab is basically etiological classification. The martology classification is basically shows how a dysplastic can be differentiated from the acquired forms, and it throws more light on the evolution of the dysplastic listhesis. But this classification of the spine deformity group, okay, into low grade and high grade, and again high grade are classified into balanced and balanced, retroverted, and unbalanced. Okay, so this, before this classification came, we used to always have a debate of reduction versus in situ fusion. So the surgeons who advocated or who debated for reduction and fusion were always considered macho, okay, like superheroes, and they used to always push these surgeons who used to do a in situ fusion down. Okay, now the treatment principles are such that there are indications when you should reduce, and there are indications where you may not need to reduce. So that is a difference that has happened after this classification has come up. So the otherwise there are significant benefits of reduction. So if you reduce, there will be more contact area between the inferior end plate of L5 and superior end plate of S1. Okay, because there will be more surface area, so that will increase the fusion rate. And because you're getting, once you reduce and fix, you will get your alignment right compared to an in situ fusion. So you will prevent progression of the slip. Okay, because if you fuse in situ, because the sagittal balance is still unattended, there's a possibility that the implant might break, or implant might loosen, and the slip might progress. And of course it improves your sagittal alignment and gait, etc. So these are the benefits of reduction. But however, there are negatives of reduction also, because you're going to put too much traction on the nerve root. There is a 25% chance of developing a neuro deficit. When if the patient is osteoporotic, when you've taken this screw purchase, the screws might just pull out when you're trying all these reduction menus, because that entail a lot of powerful mechanisms to reduce, and these are definitely long surgeries because of the difficult anatomy, and because of increased operative time, there is a possibility of increased blood loss. So in situ reduction has all the advantages. All the disadvantages of reduction are can be negated with the in situ reduction, because it is a shorter procedure, hence associated with less blood loss, and because you are not using any powerful mechanisms, there is a lower chance of implant failure and lower chance of neuro deficit, because you are not putting any traction on the nerve root at all. So in a way, in situ fusion has its advantages. The only issue is if you do it in a retroverted pelvis, or which is balanced, or a retroverted pelvis which is still unbalanced, then there is a possibility of implant failure later on, and the compensatory mechanism will still start playing, like deformity, hamstring spasm causing flexion deformity, thoracolumbar, kyphosis. These are all manifestations of poor sagittal balance, which can trouble the patient later. So these are the various types of reduction techniques. These are all age-old techniques, hardly used now. So this is one case of grade 3 listhesis which we could manage using MIS. And this is another case of dysplastic listhesis. It's almost grade 3, which we could do again with minimal access. So though if your screws are in the right place and if you have good purchase, you can manipulate the disc space. So here we have excised the sacral dome. You see, you will not see the sacral dome here. Using an osteotome through the tube and corrected the deformity and got a good reduction. So the way we do is, this is the principles. So this is a L5S1, for example, L5S1 lytic listhesis. So we put screws on the opposite side. We distract the screws. So once you distract, the disc space opens up, and then you throw a tubular retractor. You curate the superior and inferior end plate, hollow the disc out, hammer, put in a lot of bone graft and put a cage. So the cage itself, helps in indirectly reducing the listhesis. Then you compress the pedicle screws across the rod on the opposite side, and then come to the ipsilateral side and do the same thing. So that's how you reduce. So this was a case of I don't know where the X-rays moved. I'll show you these pictures. I don't know why these pictures are not showing up. So this was a case of I'll share this presentation later on. I have it somewhere else. I don't know why those X-rays have not come up.
Okay, sir. Okay.
So what I wanted to show was a case of spondyloptosis, which we did with minimal access. So you can see just the post-operative images here. This no intraoperative images. So this was a case of L5S1 lytic listhesis. So the other way of reducing is, so here you see the L5 is slipping on top of S1. Okay. Other way of doing it is called a Gaines procedure. Either this is another way of reducing the listhesis. So you do a vertebrectomy. Okay. So initially you go from the front, anterior retroperitoneal, you excise the entire L5 body. Okay. So when there is no L5 body, it is very easy to reduce L4 on S1. So then you go posteriorly, you put screws in L4, you put screws in S1 and pull L4 on top of S1. So what will happen is there will be two nerve roots in this foramen. One will be a nerve root of L4, the other will be a nerve root of L5 in this particular foramen. So this is called Gaines procedure. It's the procedure involves vertebrectomy of the slipped vertebra, that is the L5 vertebra. And when there is a balanced pelvis like this, so this is a balanced pelvis. Okay, so you do something called as a abduce procedure. So if you see keenly, so this particular lower screw of S1 is going through and through into L5 body. Okay, so L5 and S1 become the inferior body, and then that is fused to L4. Okay, so this is a transvertebral screw. Okay, the length of this screw is usually 65-70 mm screw, which is usually not in the implant set. So you have to specially ask them to make or see to it that they are available when you're doing this particular procedure. This was described by William Abdu. The other way of doing it is, you bypass L5. So here, because the L5 you see, L5 is very small pedicle here. So you part screws into S1 as well as S2. Sometimes you can put screws in the pelvis, that is the iliac crest, and in L4, and you ignore L5 and put a lot of bone graft posteriorly and posterolaterally. So now we are moving to another big topic, that is degenerative listhesis. We are done with L5S1 lytic listhesis. We are going to talk about L4, L5 degenerative listhesis. Do you want to continue or have it another day?
So we can keep it on another day, sir.
Huh?
We can plan it in next week, sir, for degenerative spondylolisthesis.
It's again a big topic, and it's quite interesting. I also fatigued, So maybe we can have it in another. It is about 50 slides.
Sure, sir. Sure. We will keep it in next week, sir.
Yeah. So I'll show you this one. The other slide.
Arvind.
Yes, sir.
Yeah, I think so that if you have 50 slides, I have Dr. Kulkarni, of course.
Hello,
so
hello, sir.
We'll do it next time.
Yes,
This was good, but very good.
Thanks. So I'll just show you the slides for patient.
Sir, I think I do have, sir. Should I share, sir? Shrikant here.
Yes, sir. Yes, proceed.
I have that presentation here.
Yes, sir.
Sir, I'm not getting your voice.
Can you hear me?
Yes, sir.
So I'll just show you this present. I don't know how to disappear it.
One second. There is a disturbance. Yes. Can you hear me, sir?
Yeah.
Yes. What you are asking, sir?
I'll just show you that case of reduction,
Oh, spondyloptosis.
Oh, spondyloptosis.
Yes. Sure.
Sir?
Yeah?
Sir, Shrikant here.
Sure.
Shrikant, I think I have that slide. Should I send it to you or should I show you here?
No, I have that presentation here.
Okay, sir.
It's not.
First, we have to unshare the screen, sir.
Okay.
Rikunj,
Yes, sir.
just thank him and can I leave for some time?
Sure, sir. Sure, you can leave, sir.
Yeah, just thank him. Okay?
Thank you, sir.
Thanks.
Yeah. Thank you, Pachore, sir. Thank you, sir.
Shrikant, you share. Shrikant is my fellow.
Sir. He will also be able to share. Dr. Shrikant, you will also be able to share. You can share your screen. Yes, your screen is being shared.
Yeah, so this is a case of spondyloptosis. So this is called the slip angle. So there are many angles described, for L5S1 listhesis. So that will itself go on for an hour, but most of them are for no use. Once this, concept of pelvic incidences come in, these have no much value. But anyways, this is called a slip angle. Superior, draw a line along the superior aspect of L5, and the angle made by this particular line with the posterior aspect of the first sacral vertebrae. It's usually about 90 to 110 degrees. So here it is reduced. And the sacral slope, we know it's 50 degrees here. Next. So look at this lumbar lordosis angle. Okay, it's usually about 50 to 60 degrees, the lumbar lordosis. Okay, so it is 100 degrees here because of the slip. Because the S1, L5 has become vertical. Next slide. So this was done using minimal axis. So if you see, this is a tubular retractor through which the discectomy is done and the cage is being introduced. We already put in the guide wires percutaneously, and we have put screws on one side. Okay. The critical point here is that the purchase of the screw should be extremely good. So for that, it is very important. Usually the good thing is, which is favorable to the surgeons, is the S1 superior end plate is extremely cortical and extremely hard because of the chronic stress at L5S1. And if you should make all attempts to get a good bite of this, terminal part of, the superior end plate of S1. This is called the tricortical purchase. If that is good, then you can manipulate the implants well and get your reduction. If you don't have good purchase, then it's very difficult to get your reduction, or it will fail the very next day. And using navigation, you can get bicortical purchase of L5 screws. That is one more relevant point here. Next slide. So once go back. Go back, Srikant. So anyways, this was the reduction that was achieved. You can see here, the slip angle is come back to its normal. It's usually between 90 and 110. So you got it back to 88 degrees. And a good contact between a lower end plate of L5 and superior end plate of S1. And more importantly, even though it is not fully reduced, it's about grade 2 now. It has become horizontal. Okay, so that way achieving a good spinal balance. So the benefit of minimal axis in spondyloptosis is, if you see the pre-op images, Srikant, can you go back to the first image? So if you do open surgery, so you have to put screw into L5 pedicle, which is in this particular direction. If you trace it backwards, your skin incision should start somewhere here. Okay. And the S1 screw will be somewhere in this particular trajectory. So your skin incision will extend beyond that. So you will have an incision which is about 20 centimeter long from here to here to get just your screw purchase right. So using percutaneous technique with small incisions, you can get the entire procedure. Only thing is it needs a lot of experience and confidence to do this with minimal axis. So this patient, we have a follow-up of about close to a year now. Thank you. So if there is any questions we can answer, with relation to with regards to spondylolytic listhesis.
Yes, anybody wants to ask a question? You can proceed.
Can I ask Arvind?
Yes, sir. Good evening.
Yeah, good evening. Okay, that excision of L5 bone, vertebral body from the front with all the vessels, bifurcation of the aorta and the vena cava and all that. So how do you go about that?
Sir, I have not done a single procedure with this technique, but you need to take the help of a vascular surgeon. There are a lot of issues related to it. So if the patient is young, you should also discuss with the patient regarding retrograde ejaculation. So the inferior hypogastric plexus is lying over L5 body. So if it is not managed well, there is a 10% chance of retrograde ejaculation. That is one. Second is those vessels are there and the anatomy is distorted. So you need to take the help of a vascular surgeon. Third is, in spite of this particular technique, there is still a 25% chance of transient foot drop. With this technique.
Yeah, so it's not. Okay, there is one condition in listhesis where a lot of bone formation takes place and it becomes stabilized.
Yes.
So how do you know it is become stabilized? Means, because of end plate destruction and the destruction of the disc space, a lot of bone formation between say L5S1 or L4-5 and it's stable.
Yes.
So how do you make that out?
So generally, this is seen in chronic L5-S1 listhesis. There is a plate of bone which is formed between the L5 and S1 anteriorly. Between the L5 and S1, there is a way of naturally stabilizing the segment. So in such a situation, earlier we used to, the principle was, since it is already fused, just put screws and stabilize it and, do a decompression. That was the earlier concept. Now we'll have to again classify it according to this spinal deformity group classification. If it is high grade and if it is still in unbalance, then you'll have to osteotomize the bone and fix it, reduce it and fix it.
Okay, right. So how much is the difference between the open method that you showed the earlier one and the miss? Means is the p-value so different? Because it can't be done by everybody, the one that you showed.
Yes, so this patient actually, many of the MIS techniques where we have extended our envelope, where we pushed our envelope, done newer indications are these basically the patients only have forced us to do them. So this lady came to me 3-4 times earlier also when I told her it is not possible with MIS. Then I said might as well try. So we got, once you position, there was some degree of mobility I saw at L5S1 disc space that give us encouragement to try and manipulate and reduce it.
But is the debridement of the L5S1 disc space so effective in MIS rather than in open?
So that doesn't make any difference, sir, because the tube is 22 millimeter in diameter. So there is enough space to excise the, put an osteotome, cut the sacral dome. In fact, it is easier with the tube because the tube is fixed, it doesn't move. So your trajectory is very well, you are always conscious of the trajectory. When you are doing open, you're not that conscious about the trajectory because the tube is fixed in that particular trajectory.
And you'd have to do on the opposite side also the same procedure?
So in this particular case, we could get, we could do it without going on the opposite side. But that is, if it's still resistant to reduction, that is something which one can do, go opposite side.
So that option is open.
Yes.
Correct. Yeah. Your concept of the balance and imbalance is very important, I think.
Yes, sir. These are basically the compensatory mechanisms. It's very interesting to read. It's very difficult to do it, show it in a webinar. But when you're standing, if you're on a podium, it is very easy to explain with the models. This understanding of spinal balance has really revolutionized the way we understand things.
Yes, sir. Any other question? Okay, sir. So, sir, we end this lecture and thank you very much, Arvind, sir, for your time and efforts. And you made it very clear.
Degenerative listhesis is next Monday, if you wish.
Next Monday we can arrange, sir. Absolutely.
Yeah.
Yeah, that would be
Okay,
very
okay.
interesting,
And
Arvind. I will
Yes, sir.
come for that. What time?
Thank you, sir.
Same time.
same time, sir. If we will arrange it at 7 p.m. in evening.
Okay.
Okay, okay. I'll be there.
Okay.
Very
Okay,
important.
sir.
Thank you.
Okay, sir. Okay.
Arvind.
Thank you,
Thank you
Arvind,
so
sir.
much, sir.
Thank you very much, sir. Thank you very much. The lecture was in detail and you covered recent advances also.
Thank you.
Yeah. Good night,
Thank you,
sir.
Arvind.
Good night.
Thank you, sir.